Ferguson's numbers stood until the Oxford study challenged him. He came out the next day and said, I've reduced my estimate from 500,000 in the UK to 20,000. But this is because of social distancing. He must know better than to say that. No?
I don't know his personality.
Okay.
To know better means you have to question yourself. And some people are not capable of doing that. And that is dangerous.
It just seems so incredibly obviously disingenuous, even to a layperson, to say that, oh, my model has changed, but it's because we were so good in one day, because the social distancing had only happened for one day, and he was saying it's because maybe I can tell we're going to be so good. I mean, and therefore that's why it just doesn't make a damn bit of sense.
It does not make any sense. If you have a model that gives results that contradict everything else, then you contact your colleagues. You say, send me your model, let me try it, let me compare what we have. Where are we in agreement, and what is it that makes my model different from yours? This is how science works. We all make mistakes, but we don't present the results without first double-checking with what other people think and what other models say. Because as a scientist, you're human.
Yeah.
We always make mistakes, but we check for it, and we know how to check for it.
And it would seem that this in particular was a moment that required very careful checking and very careful peer review. But the WHO comes up with this 3.4%. And then Ferguson's numbers are, I don't know what the percentage she was thinking of was, but it meant 2 million dead in the United States and 500,000 in the UK.
Okay, Frankenstein came out with things that were totally off the chart. And if your results are totally off the chart, you double check them.
You're talking about Ferguson?
Yeah.
You said Frankenstein, okay.
Oh, sorry.
Yeah, so say that again, Ferguson. Ferguson.
No.
Yeah.
Leave it.
Frankenstein. Yeah, right, okay.
But this double checking has never happened with these models, because you are not off by several orders of magnitude. You're off by 10, 20, 30%, 50%. But that is more than 2 orders of magnitude. Even the best social distancing cannot change something by 2 orders of magnitude.
Are we going to see these spikes? Are we going to see extra waves because of this lockdown?
3 weeks ago, that was something I was afraid of, that it might happen. What we now see is people got infected nonetheless. So we now have at least 25% in New York who are already immune. So even if we just stop right away, having 25% in the population immune is a very effective barrier against a fast spread. So we may see a rebound, but the rebound will be very low and take some time. So we will have a flat curve of a rebound that will not have any major impact on health or any other indicators.
But of course, we're being told that we do not know whether having the antibodies makes you immune. Doesn't that seem to sort of fly in the face of most immunology and indeed the whole basis for vaccination?
I don't know if I'm jumping out of the window, if I will die as soon as I hit the street. I don't know because I haven't done it yet. But experience tells that most people who jump out of the window from the 4th, 5th, or 6th floor die. And this is the same situation here. We know what all other respiratory viruses did, and there is no reason to believe that this respiratory virus will be fundamentally different from any other respiratory virus, including the coronaviruses that we are very well aware of.
What I find strange and totally illogical is that there is now this mantra that we will never go back to where we were before. And I think about it and I say, why not?
I'm John Ioannidis. I'm a professor of medicine and of epidemiology and population health at Stanford University. I'm one of the two co-directors of the Meta Research Innovation Center at Stanford, or METRICS. My research is interested in appraising evidence, in trying to understand data, strengths of data and weaknesses of data, and trying to make sure that we have the most useful information to make decisions that matter. Unfortunately, much of the information that we have collected so far, and this is not to blame anyone, it's just something that has arisen very fast and has caught us off guard in a way. It's a new pandemic. Most of that information is not reliable. We have increasing evidence that many of the key features that pertain to what this pandemic is about, how lethal is that virus, how many people it has infected or will infect, what is likely to be the eventual impact, and how effective are the different measures that we're applying. We have major gaps in practically all of those fronts. The WHO indeed released an estimate of a case fatality rate of 3.4%, which at the time of the release earlier in March, it was based on the number of people who had died as the nominator and the number of people who had documented infections as the denominator. And information from settings where we have more complete information about that denominator suggests that the infection fatality rate is much, much lower. We do have some situations currently where we are approximating that number with some fair accuracy. One situation was actually a very early experience in the course of the pandemic. We have a cruise ship, Diamond Princess, where we had an outbreak of SARS-CoV-2. Many people got infected. This is a situation where you have a closed space. People cannot really go anywhere. They live in very close quarters together for the duration of the cruise. So we had an infection rate of close to 20%, 19% of the passengers and crew got infected. And among those who were infected, as of now, 1% has died. 1% is a figure that pertains to a population of mostly elderly people. The mean age of the passengers and crew was 58 years old, and the median, I believe, was close to 65. And we know now that there's a very strong age gradient. People who are older have a higher risk. People who are young have a much lower risk. If you try to adjust for the age difference between the passengers and the crew and the general population of a country like the US, probably an estimate anywhere between 0.05 up to 1% may be more reasonable to consider as opposed to, let's say, 3.4%. I am collaborating with scientists who are leading the Italian response, and I'm trying to get their insights. And this has been a very interesting puzzle that we have been brainstorming on. There are multiple explanations so far that can be proposed on why Italy really became such a disaster. And these include the following. First of all, it's demographics. Italy has the most elderly population in Europe and one of the most elderly populations in the world. The average age of people who die in Italy is 81 years old. And also, most of these people have lots of other underlying diseases. Italy is a country that has a very strong history of smoking. It has very high rates, therefore, of chronic obstructive pulmonary disease. It has very high rates of coronary heart disease. And these are very strong risk factors for having a bad outcome in this infection. And it still remains to be decided how many of these infections are deaths with SARS-CoV-2 versus deaths by SARS-CoV-2. There's also other things that probably got wrong in Italy. Italy has a relatively low number of ICU beds per population. It has about a third of ICU beds per population compared to the US. And their system is running at full capacity practically every winter. But you realize that a system that is so close to saturation, to having its maximal capacity, if you add just a little bit more, it can very easily collapse. Italians were the first to be hit in Europe, and that was an exotic pathogen. Everybody thought that they had to do their best. So they said we need to admit these people to the hospital even if they had modest or not so severe symptoms. This resulted in a very bad decision making, and I think that this is something that every other setting that is hit by an epidemic wave needs to avoid. By admitting these mild or moderate cases very quickly, they became saturated, and when they started getting the severe cases, they just had no room for them. So also the hospital became heavily colonized with that new virus. This is a virus that can stay on surfaces. Many of their medical personnel got infected in that heavily infested environment. So there's a lot of factors that created like the perfect storm. I would be very careful to make inferences based on single case reports and anecdotes. I feel that every single patient has the dignity of his life, and every single patient is a different story, and we have to give great respect to that life and that person. But I'm worried that if we see in the news presentations of single cases as heralded being something that I have never seen before, this is so horrible, that's the worst case of severe respiratory distress syndrome that I have seen, we are falling into a trap of sensationalism. I mean, can you imagine what would have happened if 60 million deaths that happen every year in this planet, we had a meter counting them one by one and having stories written for each one of them? It would be horrible. I mean, we have gone into a complete panic state, measuring so far a sizable number of deaths, but nothing close to the total cumulative mortality that we see both in this country and around this world. I think that that panic component and that overemphasis of media attention is probably making things worse. We do want to sensitize people to follow instructions, to try to keep the public health measures, to shelter in place if they have sheltered in place, but we don't want to get them scared. We don't want them to get into panic. This doesn't really help. I think that there's a very high chance that we are exaggerating. As we discussed, many of the features of this pandemic, of course, they're serious, but I think that the estimates are exaggerated. And I think that there's a risk of really making some fundamental decisions about the structure of our civilization, of our society, of our future that may not be appropriate. I think that we have no clue how a society would work if you need to build it around a construct where everything is done from a distance. So there are some models that suggest that if you go down that path of basically lockdown, you may need to wait for 18 months. And I'm extremely worried about that scenario. I'm not sure that our world, our civilization could survive that. I think that there is not just millions of lives at stake, which is the pessimistic scenarios about SARS-CoV-2. It is billions of lives who might be at stake if we have to protract that for so long. And my plea is to get the best data, because we have very serious decisions to make. We should make them as informed as possible. I'm perfectly happy to be in a situation of practically lockdown in California, more or less, shelter in place. But I think very soon we need to have that information to see what we did with that and where do we go next. We need to learn. I think that there is a risk that in this situation, there may be other conflicts and other interests that get interspersed and they kind of take over the entire agenda. That should not become a political debate. That should not become a debate between people who may have different financial conflicts or other conflicts. It should be something that we should all be united about, saving lives, getting the best outcome, and really knowing what are the next steps about what we do with this epidemic and what we do with our world at large.